Hello. Today I'm going to demonstrate the procedure for how to perform an endotracheal tube intubation. So this is something you guys are going to perform frequently in hospital, in emerge, in different places like critical care, the OR, and so on and so forth. So first we're going to talk about the actual tools that you'll need to perform the intubation. So first off, we're going to start with the endotracheal tube itself. So this is a tube. It essentially is made of a plastic material. It has a cuff down here at the end that you're going to inflate once it goes through the vocal cords. You're going to use the 10 cc syringe that we spoke about in our class programming to inflate that cuff and essentially to test it and make sure that it's a patent cuff. So the next tool that we are going to demonstrate is the use of the laryngoscope. So this is your handle here, and this is your blade. Your blade also has a light at the end, so you can help with visualization of your airway structures. Next, we have our tube holder. So this essentially is going to go on the patient's face. It's going to secure the tube and hold it in place so that it stays where it's supposed to, so you can maintain effective oxygenation and ventilation. The next tool that you'll need is what is called an ambu bag. And you'll have oxygen tubing that's going to go directly to an oxygen source, giving 100% oxygen. This will be used to manually ventilate your patient and to pre-oxygenate your patient with 100% oxygen before performing the ART and active intubation itself. We also have a mask, so this gets attached to the ambu bag. So before you actually put the tube in the patient, you can pre-oxygenate the patient's face with this mask, delivering 100% concentrated oxygen breaths to the patient. We have a lubricant that goes on the tube to help it glide through the vocal cords. We have our cuff pressure manometer, and that is to help see the pressure that's inside the cuff of your endotracheal tube to make sure that it's not too high, because having too high of a pressure can cause necrosis of the trachea. We have our end-tidal CO2 detector to help confirm placement once the tube is in. So what you're looking for, you'll see color change, and when you have it in the trachea, it'll color change from purple to yellow, and when it's in the esophagus, which is the wrong place, it won't color change at all. So that is one of the ways that you can be sure that you have your tube in the right place. We have what's called an oral airway. These come in multiple different sizes. As we spoke about, you're going to confirm your sizing from the tip of your mouth to the tip of your jaw to make sure that it's the right size for the patient. And this just helps facilitate the bag mask ventilation that we spoke about already. And last but not least, we have our inline suctioning. So this essentially is what goes attached to your endotracheal tube, like so. And you can go down and suction any secretions or any buildup of old gunk that's down in the patient's lungs and clear it out that way. So that is it for the demonstration of the tools, and we'll move on to the procedure itself now in just a second. Okay, so before we get to a patient's bed space and perform the intubation on the patient, we're going to actually make sure that all of our equipment is functioning properly. So the first thing you want to make sure is that your ambu bag is connected to a 100% oxygen source and turned on. You're going to make sure that your reservoir bag fills up with oxygen, and you're going to make sure there's no leaks. So you're going to occlude and you're going to squeeze and make sure that it holds pressure. The next step, you're going to essentially let go of your hand, squeeze the bag, occlude again, and you want to see that it refills like that. That is your safety check. If that passes, no leaks, you're good to use it. The next thing that you're going to check is your suction equipment. So anytime you approach a patient's bed space and you're going at their airway, you want to make sure you have a functioning suction available. So what you'll do is you'll turn it on and you'll make sure you occlude. You'll check that you have suction pressure. You'll look at your wall, make sure that everything's fine, let go, and you'll see that you got good suction pressure so that if anything happens, they cough, spit up anything, vomit, you can suck it out, no problem. Okay? We always keep these handy and close and tuck just underneath the patient or the pillow if they have one. So that is it for function of, equipment prior to. The only other thing I like to do is to make sure that my laryngoscope handle and blade light works properly, so that when you get into the patient's airway, you can see all the visible structures. If you have any issues, you would just replace the battery like so from in this area. Okay. Okay, so now we're going to perform the act of actually intubating the patient. So just like we discussed in class, through our PowerPoints and whatnot, patient positioning and pre-oxygenation are key. So when I'm looking at patient positioning, you want to have your patient lay flat. You want to make sure that they are up in the bed close to you so that you have a good view. You want to make sure that you can pre-oxygenate with no trouble whatsoever. So I will make sure the mask fits appropriately, usually from the bridge of the nose to the bridge of your chin. The bag, we already performed our function check, so you're going to use a C with your fingers to press down and an E to pull back. And now you're looking at the patient's chest and making sure you can get chest rise and pre-oxygenate no trouble. We're looking at his chest. We usually pull the covers down so you can get a good visual. And we have good chest rise here. If you weren't having good chest rise, remember we could also insert our OPA. So we could go ahead. This helps move and displace the tongue so that there's no obstruction. And then you can continue to pre-oxygenate. And we know that we pre-oxygenate for about 3 to 5 minutes. And you usually see the oxygen saturation is greater than 97, and we know that we're good to go. So the only other thing that we will have is everything ready. We'll usually have an assistant. So right now I don't have an assistant, but I've prepared everything to the best of my ability to give you a really close idea of what is required. So patient is pre-oxygenated. We're at 100%. The physician has administered the medication to sedate the patient. I took out my oral airway. I'm going to prepare my laryngoscope. That's ready to go. I have it here. I have my endotracheal tube here, ready to go. I've checked the integrity of my cuff. Remember, we discussed 10 cc's to check. Make sure that it holds pressure. Might need a little bit more in this one. And as you can see, good integrity of your cuff. You'll deflate it so that for insertion it's nice and flat to the shaft of the tube itself. We lubricate it just to make sure that it has the ease of going through the cords. I have my syringe ready to reinflate my cuff, because having the cuff reinflated decreases the risk of aspiration. I usually take my end-tidal CO2 and have it connected, so that is one less step I need to perform once we have the patient intubated. I'll stylet my tube. So a stylet essentially is just a tool that you insert into the endotracheal tube, and it just makes it a little more rigid for insertion. So you can essentially maneuver the tube, put any type of angle that you'd want on it for insertion into the patient. So everything is ready to go. Okay, I'm going to take my laryngoscope blade. I'm going to have the patient in sniffing position like we discussed, which essentially is just going to line up all the airway structures and anatomy to make it easier. You're going to insert your blade into the right side of the mouth, sweep the tongue, get a good view of your vocal cords. You're going to enter through the right side of the mouth, inserting the endotracheal tube in through the trachea and the cords. You're going to come out with your blade. I'm going to remove that stylet. I'm going to inflate my cuff. I'm going to remove the 10 cc syringe. I'm going to confirm placement by placing the end-tidal CO2 over and bagging the patient to make sure we have good chest rise. So I see good chest rise here. As you can see, I have the patient is still saturating well. His oxygen sats are 98. I've got color change on my CO2 detector, and I'm also going to confirm placement by having a listen. So I generally am going to have a listen like so. So you'll take your stethoscope, you'll bag the patient, and then listen over the belly to make sure that you have no ear entry over the belly, because that would mean that the tube is in the wrong place. So now that we've confirmed and we have good chest rise, we can secure our tube. So we can go ahead, take our tube holders, secure it. At this point, we usually have somebody who is here bagging, so the patient is still being oxygenated and ventilated like so throughout the securing process. But I don't have the extra set of hands right now. But just know that the patient is doing well, no issues, airway secured. The intubation was performed with no complications. And we secure these just enough that you can only fit 2 fingers so that it keeps it nice and snug. And then you can continue to oxygenate and ventilate your patient until a ventilator comes, and you can put the patient on a ventilator, and away we go. So remember, we always confirm post-intubation with a chest x-ray to make sure that the tube is where it needs to be, because sometimes it can be a little bit too high or a little bit too low. So it's nice to confirm and just make sure that your x-ray, the tube is looking great. But otherwise, other than checking my pressure of my cuff for safety, I would take my manometer, insert it on this blue balloon, and have a look that my cuff pressures are between 20 and 30 in the green zone, which they are. So we know that we have performed everything the best of our ability. We can add our suction catheter now, and that's just something that we can essentially put in after the fact. Doesn't have to go on right away. You can go on at any point, and it's just facilitates keeping everything a closed circuit. So when you perform suctioning, you would attach your suction catheter to the inline, and you can go ahead, go down into the patient's lungs, all the way down. Any secretions or gunk you can suck out without having to take them off the ventilator. Apply your suction and just slowly come up, and you're clearing all the secretions out of the patient's lungs without having to, stop ventilation or oxygenation or anything like that. I hope this helped visualize everything we've been talking about in our blended sessions online, and I hope that once we get into lab, you can practice and have just as much fun as I did. Thanks.